glad to have you all on the call for our state-specific discussion this morning about newborn screening. Before we get started, I did get a little bit of feedback that I wanted to go through real quickly, and that's just that some people are having trouble hearing other task force members. They've expressed that they can hear the presenter fine, but they're actually having difficulty hearing each other. So I was just hoping that we can all really try and focus and speak up, because, I mean, this task force was really created for us to learn from each other just as much from the presenters. So we really want everyone's voice to be heard. With that, the rest of the kind of housekeeping items I will save for the end. We're very fortunate to have Ms. Amy Gaviglio from the Minnesota Department of Health with us this morning. So Tam, if you want to go ahead and give her control. Amy, I'll let you introduce yourself a little bit and then start the great presentation you have for us this morning.
All right, thank you, Elizabeth. Can you see my screen now?
I cannot yet.
Okay.
Okay.
Oh, there it is. Yep.
All right, yay. So my name is Amy Gaviglio. I am by training a genetic counselor, and I work as a genetic counselor in the newborn screening program, and also supervise the short-term follow-up unit for newborn screening in Minnesota. I'll move on. So I talked to Elizabeth a little bit about what would be most helpful for you as far as a talk from this perspective, and she shared some of the questions that you guys have had from all of your calls and your get-togethers. And so based on that, I've structured my talk as follows, and I'll go through basically what it takes to operate a newborn screening program, inclusive of the operations and the considerations that a state needs to make when they're running their program, funding and legislation, state versus federal initiatives, and why newborn screening really is a state issue, local resources and services that state programs utilize, and then how individuals can get involved with the program and really make a difference. Please feel free to stop me at any time. I have a structured PowerPoint, but I am happy to get off on tangents because I want this to be as helpful for you as possible. So interrupt me at any time. That's perfectly fine. So I think whenever you're looking at initiatives around newborn screening or looking at projects around newborn screening, it's really helpful to know all the things that go into operating a program and where some of the things that maybe aren't working so well are, so that you can focus projects on those areas. And very briefly, concerns that states need to consider include. Do you need to stop? Do you need to stop? Are we still good? Are we still good? A lot of noise on the other end.
If everyone can mute their phones, it sounds like we're getting a little bit of feedback. Okay, go ahead and try now.
All right, no problem. So concerns that state programs need to consider include educating all the stakeholders. Of course, the specimens are drawn in the hospital, so how you're going to get the specimens from the hospital to the lab, what diseases you're going to screen for in your state, how you're going to screen for them, what testing methodology you're going to use, if you have a positive result, how you're going to report that out, follow-up, which is broken up into both short-term follow-up, which is defined as the follow-up needed from the positive result to a diagnosis or it being ruled out as a false positive, and long-term follow-up, which is the support provided to families after a diagnosis has been made. And then there's quality control and assurance. That's both obviously in the lab, but as well as for your program itself. And then storage and use. And I'll go through each of these individually, but I just wanted to make a disclaimer that I'll be talking about what we do in Minnesota, as that's what I'm most familiar with. but that may not be the case everywhere. So just be aware that what I say here may be particular to Minnesota. So an increasingly important component of newborn screening is education. And I think in the past few years, education has become a lot more to the forefront of newborn screening because screening is getting increasingly more complicated, both in the diseases for, but as well as the subsequent storage and use and the issues around that. There's a range of audiences that programs focus on, and it ranges from the general public. We want the public to be aware of the program. Parents to be, again, that's more of an awareness level, so just knowledge that this program exists and what they can potentially expect after the birth of their child. For new parents, the education is a little bit more in-depth. It's really talking about how the screening works and what they can expect if there's a positive result. And then, of course, the providers, and here it's really on the expectations of them as providers, both for the collection of specimens and the education of parents and the how-to by way of what we expect from them after a positive result, how they should follow up. So for providers, we focus on two different levels of education, general background on, again, expectations of them as providers, collection information, testing methods, basically what to expect if we call them, how to talk to parents about newborn screening and storage and use. And this is done in a variety of ways. A lot of states use a provider manual, so either electronic or hard copy, which walks them through the whole program. We provide a lot of trainings. We go to a lot of grand rounds as well to provide information. And it's really important for a state to focus on provider education because providers really are the mouthpiece for us here at the state to parents. We're not sitting in front of parents and we're not having that discussion. We can put out the best materials we can think of, but if they're not being discussed or the person discussing them doesn't have the background, then we're really failing as a state to educate. So provider education, it may not seem like that important, but it really is, it's a huge focus for us because they really need to be on point with what we expect of them so that they can tell parents exactly what we want them to be hearing.
Right. So could I just stop for a second and explore this a little bit?
Absolutely.
So, sorry, and stop me if you want to wait till the end, but this is an issue in D.C. With our newborn screening program that the D.C. Department of Health really has no training materials at all for providers. And so I'm just wondering if you could specify a little bit what your state DOH responsibilities are, and if they're formally set out, in law or regulation, here's what the DOH has to do in order to implement newborn screening program by educating providers.
No, that's a great question. In Minnesota, it's not specifically mentioned in statute. It says that we will provide information. But it doesn't specifically talk about how we will ensure that that education is being received, if that makes sense. So I think this is something that every state struggles with, is you put out the best materials, you spend a lot of time on the materials, but then you need to make sure that they're getting to where they need to go and that the providers are getting that information. We've typically found our provider manual. I know we just did a survey, and I think maybe 5% of providers even knew it existed. So we're really trying to rethink about how we do provider education. And our experience offering trainings, going to the clinics, going to the hospitals, doing grand rounds, that's a lot more effective because you're in their face. They more or less have to listen to you, but then you get that good dialogue as well. Did that answer your question to some extent?
Well, it does. I mean, the fact that you have a provider manual that the state put together is represents an effort already that our particular jurisdiction does not have. So.
Right. Well, and one thing that we've done is we're pretty close to the University of Minnesota, who has has the biggest medical school, and we have all incoming med students rotate through the lab. They just do, it's a day, not even a day, it's maybe a couple hour tour of the lab, and we give them a lot of background on screening. So we try to hit our providers early as well and get them basic information about screening, and we've found that to be very beneficial.
Yeah, that's a great idea. All right, thank you.
Yeah, no problem. So another level of education for providers is that what is commonly known as that just-in-time information. So this is generally when you're talking to a provider with positive results. So in this case, it's really talking to them about the specific disorder and what we expect as far as follow-up for them, and then contact information both for the appropriate specialist and then for us here at the Department of Health in case there's any issues or if they have any further questions. For parent education, this is a picture of the front of our brochure, and historically parent education for newborn screening has been in the nursery, so after delivery and before the screen is done. And I think all of you are probably well aware that that is quite possibly the most horrible time to inform parents about anything. And so it's really been deemed, I think, recently that this approach is really insufficient, that it's not an appropriate time to provide education for parents to make decisions, especially on something that is becoming, like I said, increasingly complicated. So given that there's been a big call for increased parental education about newborn screening in the prenatal period, and the idea behind that is it gives parents more time to get a better understanding of what screening is, what the purpose of it is, and allow them to make a truly informed decision on whether they want to have screening or not. And this has been supported by a whole host of national organizations. So in Minnesota, we have a big initiative now to do prenatal education, and this is a picture of our prenatal brochure. It's very simple, and like I said earlier, the goal in prenatal education, I think personally, is more or less an awareness. You don't need to inundate parents at this time with all the details, but to let them know that this program exists, this is what happens after the birth of your child, and what we're looking for. And then so that's on the front, and then the back has just a story from one of our parents talking about how they really didn't think they needed screening because their family history is clean. They have no history of these disorders, and then they did find a disorder in their child, and how thankful they were that they went through with the test. So I think we're going to start to see a lot more prenatal education in newborn screening. I know states, including ourselves, we've had some issues just getting the OB community on board with providing this education. It's something that they don't necessarily feel is their job, but slow and steady, and I think we'll get them understanding the importance of educating about screening in the prenatal period. So the next step really is you have your hospitals who are doing the newborn screens and how to get the samples to the lab. And this may seem like a minor detail, but it is really important, especially when you're in a bigger state. You can utilize hospital courier systems. That's really only helpful, I think, either in small states or for those hospitals that are near the state health department. What we do here in Minnesota is we have our metro hospitals. We're located in St. Paul. So we have the hospitals in the 7-county metro area utilize their courier systems. And then for those hospitals that are outside that area, we actually pay for UPS next day for them to get specimens to us. And it's really important, I think, to ensure that the samples are received in a timely manner. One, that's pretty obvious, but that they're received consistently throughout the state, because you don't want to be introducing any health disparities based on location. And so we work really hard to make sure that whether you're born across the street or up in International Falls, that we are getting the specimens in more or less the same time frame. So that's something that states, I think, spend a lot of time trying to figure out how to get the specimens to the lab. The next part is the state panel. So as you're probably aware from previous talks, that there is a nationally recommended screening panel, and that's kind of those primary conditions that every state is expected to screen for. And then there are a list of secondary conditions. And whether a state decides to add those secondary conditions really depends on a host of things. And I think number one is probably funding. How much money do they have to add this disorder to the panel based on the cost of the technology to screen for it, resources available for follow-up, and then, of course, the population that you are serving. It may make sense for one state to do a certain screen based on their population, and it may not make so much sense for another state. So when deciding about secondary conditions, I think we look at all four of these and make sure that it's something that makes sense for our particular state. Another consideration that states have, I can't speak for every state, but I know that when we add a disorder and the fee goes up for the newborn screen in Minnesota, we start getting concerned about reimbursement because the fee may go up, but the reimbursement stays the same, and you're really putting hospitals in an awkward situation. As a state, we don't control reimbursement rates. It's usually newborn screening is embedded in the package fee for births, so you really have to work with other programs or other insurance carriers to look at reimbursement. But I do think it's something that states need to look a little bit more into as the fee continues to increase. So in Minnesota, we screen for 54 disorders, and we're actually a public-private partnership. So we do some of the testing here at the state lab, but then the Mayo Clinic down in Rochester does part of our screening as well. So they screen for the amino acid disorders, the fatty acid disorders, and the organic acid disorders through tandem mass spec.
Sorry, quick question.
Yeah.
On the previous slide, you mentioned the Secretary's Advisory Committee, and you have your list of disorders. So what is the process now if the Advisory Committee and HHS adds a condition? Like they did SCID, and now they're doing congenital heart. How does that work in your state? Does it just automatically go on your list, or is there a process?
Yeah, so for our state, when the Secretary's Advisory Committee recommends a disorder, we don't just simply add it based on that. What we do here is it goes to our Screening Advisory Committee. They have to approve it. And usually before we even bring it to our advisory committee, we do a lot of the background work. So we look at what do we think the incidence is in the state. We get cost savings, cost effectiveness estimates. The lab does a lot of validations, making sure that we could actually screen for it here. And then we bring it to our committee. They vote on it. If it's voted to be added to the panel, it's brought to our Commissioner of Health, who then has to approve it. Once the Commissioner of Health approves it, then only then is it officially on our panel. So, yeah.
Hi, sorry, this is Natasha. Can you talk a little bit about some of the people on your advisory panel, just to get a sense of the range of different people who are part of those conversations?
Yeah, absolutely, and I'll talk a little bit more about it too in a little bit. But okay. Our advisory panel, and I think this is true probably of all states, is really a mishmash of people. It includes obviously a lot of our specialists. It includes primary care providers, hospital nurse managers, But it also includes a lot of representatives from advocacy groups. So we have our chapter, March of Dimes, president, and a lot of parents, both parents of children with PKU or organic acidemia, or just parents who are interested in newborn screening, maybe because they had a positive screen. We have genetic counselors on there as well. So it's a great mix, and I think it's necessary to have that mix.
Great, thank you.
Yeah, no problem. Once you've decided what disorders you're going to be screening for, it's also the next step is really to look at how you're going to be screening for these disorders. And this is an important thing to know, I think, is that even if states have the exact same panel, they may be screening for things in different ways. And what you're looking for in testing methodology is obviously a test that has high sensitivity and specificity. So you want to have as little false positives and as little false negatives as possible. You need high efficiency. All state screening labs are high throughput. They're getting hundreds, often to thousands, if you're in Texas, samples a day. And so the testing methodology has to be very high throughput, has to be highly efficient. Some states add second-tier reflex tests, which is a way to increase your sensitivity and specificity versus just doing a first-tier test. We happen to do quite a few second-tier tests here in Minnesota, and that's largely because we work with the Mayo Clinic. There are some disorders where you could do 2 screens for the same disorder. So, for example, congenital hypothyroidism, you may look for just TSH level, or you may look for TSH and T4. For galactosemia, you may look at whether the enzyme is deficient, so the GALT enzyme, but you might also want to look to see if the product is building up, so the total galactose. And states really choose different ways to screen for each disorder. So just be aware that even though you may look at a panel and it may look exactly the same, the way they screen for disorders may be a little different. And then, of course, there are those states who actually get 2 complete screens every time. And so you have your 1 screen states and your 2 screen states. So what do we do with positive results, and who calls the results out? Generally, results that need to be called out fall into one of 2 categories. So they're either positive or abnormal, or they're what we call unsatisfactory. So there's not enough blood, there's too much blood, someone spilled coffee on there. There's a whole range of reasons for unsatisfactory results. And then you want to think about who are you going to call these results to. Are you going to call them directly to the family? Are you going to call them to the primary care provider, to the specialist, and what information should be provided to make sure that the process after a positive result or after an unsatisfactory goes as smoothly as possible. So generally, turnaround time from the time that a lab receives results, at least here in Minnesota, our turnaround time is about 3 to 5 days. Normal results are just sent back to the submitting hospital. Unsatisfactory results are also sent back to the submitting hospital, but we call them and request a repeat sample on that child. For abnormal results, we employ 4 genetic counselors in our program, and it's their job to call results, abnormal and positive results out. We call results to the primary care physician. We do not call them directly to the family, and we've just found that a call from the health department to brand new parents really does not go over well. And I think it's a lot better received when it's coming from someone that they have a relationship with and someone who can offer for them to come in. If we were to call, we really can't offer them anything. They can't come and see us. So it works a lot better for it to come from the primary care physician. So when we call the results out, we talk to the primary care physician. We let them know about the result. We do some phone counseling about the disorder, and let them know what the follow-up is gonna look like. And then we fax them an information packet, which includes a fact sheet for the parents, a fact sheet for the provider, a list of the specialists that they can call for the particular disorder, the report, and then a sheet for them to fax back to us to let us know what their plan is. Once we are done calling the primary care physician, we immediately call the appropriate specialist. So whether it's a metabolic specialist or a hemoglobinopathy specialist, we call them, we let them know that there's this result, and then we send them a fax of the report to the specialist. This has worked really, really well for us, and what we do then is the specialist keeps in contact with us and lets us know if they don't hear from the primary care provider, then we will step back in and recall the primary care provider and try to figure out what the holdup is as far as follow-up goes. Submitting hospitals will receive abnormal and positive reports as well, but we let them know that if they see a positive result or a positive report, they don't need to do anything because we've already taken care of it. So every once in a while we get calls from hospitals who think that they let a child slip through the cracks, but by the time a hospital receives their reports in the Mayo, we've already called it out and follow-up should already be started. So short-term follow-up, this is really it's really starting from after the genetic counselor calls the results out to the final diagnostic labs that either let us know that, yes, this child is affected, or no, this was a false positive. In our area, short-term follow-up also includes missing specimens. So in Minnesota, you can refuse screening for any reason, but we need to have that refusal paperwork. So we need to delineate between families who refused and families who may have simply been missed in the hospital. So we match all of our specimens with vital records, and when we have a birth certificate without a specimen and no refusal paperwork, we call the hospital that the child was born at and try to figure out what happened, and either request that they do obtain a specimen or that they fax us the refusal paperwork. So this is a really nice process that helps us ensure that every child is accounted for.
I have a question. This is Christy Weiss.
Yeah.
You keep referring to hospitals and the system with hospitals. What if a mom has a baby outside of a hospital system?
Yeah, that's a great question. Home births are becoming increasingly more prevalent in Minnesota. We work with our home birth population very closely. We know all of our midwives, and so our midwives they often collect the specimen.
Okay.
So they know how to collect the specimen, and then they send it to us. We do work with them because they tend to have families who don't have insurance or are unable to pay the fee. So we provide free cards to home birth populations if they can't afford the card. So the midwife will just call us up and let us know that they have a family who can't afford the card but want screening, and then we'll send them a free card. So yeah, I think we have a really good working relationship with our home birth population. We also have a pretty large Amish population, which I know no one believes when I say that in Minnesota, but we do. And we've worked really closely with their midwives, and actually we have a great compliance with the Amish population for newborn screening in Minnesota.
And do you also do the check with the vital records then, with making sure that a family has gotten it done?
Yep. So that, the downfall with vital records is that it requires a birth certificate to be there. And I think that that population tends to take a little bit longer to file their birth certificate. So, I think that's a little bit of a gap they do eventually come up, but it may be
too late
later where it's not, where screening, the effectiveness is kind of past its prime. So yeah, we do, if they file their birth certificate, we know, and we do that matching. But if they don't file for 6 months, then we have no way of knowing that they exist.
Great, thank you.
Yeah. For positive and abnormal cases, again, I mentioned that this is really ensuring that children with the positive results get their needed follow-up. And so we work both with primary care and our specialty care. We actually go to, for metabolic clinic, we go to care conference with our specialists every week to make sure that the children that we called out got into the clinic, that there were no problems as far as transportation or barriers. And then we just continue to work with them until we have a final outcome. One thing that I think doesn't get said enough with screening is that false positives and false negatives exist. And newborn screening is not a diagnostic test, it is screening. And false positives are inherent, they're going to happen. And part of that is by design. A lot of times when you're setting your cutoff, you're setting it so that you don't miss anyone. And in order to not miss anyone, that means you may catch some kids who shouldn't have been caught or who don't have the disorder. Every program tries to reduce false positives while also keeping false negatives low, but both are possible and both happen. And really why I'm harping on the false negatives is because we've seen a lot of physicians miss cases because they assume that a negative newborn screen is the end-all, be-all. So they don't think about CAH or one of our conditions, even though the child is classically presenting with it because the screen was negative. And I think this is something that programs need to focus on a little bit more because it is screening and the disease can present in an unusual way. And so it's important for providers to be aware of the fact that these can happen and that if they have any concern that they should follow up on it even if the screen is negative. So the final and probably most controversial issue of newborn screening is really what happens after screening, and that's the storage and use of residual dried blood spots. A question that I receive a lot from parents is why do you store them in the first place? What possibly can be of use of these dried blood spots? When I think of uses of residual dried blood spots, I find that they generally fall into 5 main categories. The first one is quality assurance and quality control. So we need to make sure that our testing equipment is accurate and that the results we obtain one day are the same as the results that we may obtain the next day. In order to do this, you need to calibrate your machines and provide, do validations and do double checks on the machine. And really the only way to do this is with the same type of sample that you're going to be screening on, which is a newborn dried blood spot. A lot of people ask us why we can't just use our own blood, and newborn blood is very different than adult blood. Some of the analytes that we use in screening are not present in adult blood, so we can't. There's no substitute for the real thing. The second one is new test development. Obviously, you need to be able to make sure that you could actually screen for a test or for a disorder in the newborn population. And certainly, when newborn screening started, it was one disorder, PKU, and today it's upwards of 53, 54 disorders, and that wouldn't have been possible without residual dried blood spots and developing these new tests. Confirmatory diagnosis and clinical testing, those kind of fall hand in hand, but they can be used for further health-related testing. This is generally done with informed consent from the parents, but we've had cases where we have a family who had a child who died, and now has a younger child with similar symptoms, and there's new genetic testing available, and they may ask us to pull the specimen, the deceased child's dried blood spot, to do genetic testing. Again, those types of uses are generally done under informed consent circumstances. The most controversial use, of course, of these is for public health studies or public health research. These specimens are very appealing to researchers, and primarily it's because they represent a birth cohort sample. Most states have a pretty low refusal rate, less than 1%, so you're looking at a sample that virtually has no bias, and it's a sample that really is unattainable any other way. So for population-based studies, environmental studies, these specimens are very, very appealing to researchers. So again, from state to state, you're going to see a lot of variation in not only what they use the dried blood spots for, but whether it's mentioned in statute, whether it's mentioned in their educational materials, how long they store for, how they store for, as well as whether there's a lot of controversy in the state or whether there is none. I happen to be in a state where there's a lot more media attention on storage and use. So I think we'll have a lot of changes in our protocols and our processes in the very near future regarding residual dried blood spots.
Can I ask you a question about that? This is Bill Bell in Texas. We've had a lot of controversy in our state with this also for, I think, many of the same reasons. I was noticing in some literature recently that a family has filed a lawsuit against the Department of Health in Minnesota. What is their main concern? What is their grievance that they're citing in that lawsuit?
Yeah, so we have 3 lawsuits right now. Our first one is Bearder versus the state of Minnesota, and that was the one that just recently had a Supreme Court decision. And their main argument, after you pared everything else down, was we have a genetic privacy statute in Minnesota. It's statute number 13.386, and it talks about what can and cannot be done with genetic information without informed consent. And we felt that the dried blood spots were not genetic information per se, but the Supreme Court just ruled otherwise. So it was really that we were in conflict with that statute, was really, I think, what that particular lawsuit boiled down to. The subsequent lawsuits are class action suits, so seeking damages at that point for being in conflict with the genetic privacy statute. Does that answer your question?
Yes, so they're claiming that they were illegally obtained and used for purposes without clarification of families.
Correct. Yep, and so the Supreme Court decision was very narrow. They really said that we could use the samples the way they put it was we could screen the newborn, but we couldn't do newborn screening, which means that you can use it for the purpose of screening the newborn and screening the newborn only. So they cannot be used for any quality assurance or quality control, any other uses outside obtaining a newborn screening result for that particular child.
Can I just, was this the Minnesota Supreme Court, not the U.S. Supreme Court?
Correct, yes, I'm sorry, yes, the Minnesota Supreme Court.
What a lot of people don't realize is that the quality assurance is an essential part of it because of the fact that the genetic demographic for each region is so diverse and so different. What way work in Minnesota doesn't work in Texas and so forth. It may not even look right down the street.
Right, absolutely. All right. So the really kind of what I consider the final part of newborn screening is the long-term follow-up, and this is really for children with and their families with a confirmed diagnosis. The role of long-term follow-up varies again from state to state, but it's essentially making sure that these children have access to resources, whether it be insurance or special needs accommodations that they may have, support groups. Like I said, states really vary in the definition of long-term follow-up, and this is probably the part of newborn screening that is least defined and least, I think, understood as far as what it should all encompass. So move on to funding and legislation. As I'm sure you're well aware, newborn screening is state mandated, and the fee is usually set in statute if there is a fee, and is based off of estimates from programs on how much they think it will cost to do all of the testing and the appropriate follow-up. And statutes really vary on what they address, and this is a great website, I think, that where you can easily go to every state statute and look and see, what they address by way of the fee, by way of advisory committees, by way of storage and use, because they are all very, very different. So state versus federal, why is screening a state issue and not a federal issue? Part of it is just simply historical, which I feel like is kind of a cop-out answer, but that's just the way screening arose, was state by state, and historically that's just been the case. There also, I think it continues, however, because there are various state priorities. States have different priorities on where their funding goes, and that varies by year to year as well. But then there's also population differences. What works for one state might not work for another state. What disorders are appropriate to screen for in one state might not be in another state, just dependent on ethnicity and variations. Different funding sources, different definition of what screening is, and how encompassing the screening process is, I think has really led it to continue to be a state issue. That being said, both federal and state governments make policy regarding newborn screening. States, their policy generally is to create and manage the screening programs, and then federal interactions or federal initiatives are really to support states with funding, promote the development of policies, guidelines, and then help a lot with program improvement and quality assurance. So you'll see the CDC has a quality assurance program for states surrounding newborn screening. So the local resources and services, you may have heard about the regional genetics collaboratives. These are very heavily newborn screening focused, and there are 7, I just had a quick count, there are 7 collaboratives, and I think these are really important to be aware of and to get involved with, because you really learn a lot at these meetings, because they are so newborn screening focused, and you get to see the perspectives of a variety of states that are within your region, and I think it really speaks to how much variation there can be, even in states that are relatively similar. So Minnesota's in Region 4 Genetics Collaborative. This is our website, but you can see that you can find a lot of information on these particular websites. I think they're great for learning more about newborn screening and the variations between states. I know we have a few online learning modules that you can take. They're free. They're fantastic, as well as different projects, and you can see the different contacts. Most states have a face-to-face meeting a year. Each year, if you can somehow get involved in those, I think you would learn a lot, and you would make the connections that you're really looking for if you're trying to move a project or an initiative forward. I mentioned before program advisory committees. I believe most programs have advisory committees that are actually created by statute. So the statute dictates that a committee needs to be formed. It may even dictate who the representatives need to be. I believe Minnesota state statute actually lists out different representative groups that members need to be a part of, and may even talk about how often they need to meet. So I mentioned this earlier, but members may include parents, advocacy group members, healthcare providers, which is a huge range, but actually parents, I think, are probably some of the most involved, or the public in the advisory committees. Our president has been a parent for as long as I can remember, so they really hold a huge stake in program advisory committees. And the purpose varies, but it's really to discuss issues related to newborn screening in the state, which is often inclusive of voting on whether disorders should be added to the panel. So how can you get involved as an individual? I think it's really important to know that in newborn screening, individuals historically and continue to make huge differences in screening. I always say that our program is so largely driven by the public and by parents, and I think that's true of a lot of states. So if you have something that's close to your heart or something you want to move forward, I think the first step is to know your state's newborn screening program manager, set up an appointment, get to know them and some of their key staff, because they're going to be the ones who are going to help you move things forward. Attend advisory committee meetings. These are public meetings. We love when parents come or the public comes, because it shows a level of engagement that you can't get from just from your members. So contact the program manager. It may be on the website. Look and see when your local advisory committee meetings are. Or if you have something you want to talk about, ask to be on the agenda. The agendas are usually pretty loose, at least in our state they are, and so we're always looking for individuals who want to come and speak about a particular issue. And then the last thing is to connect with local groups. So look for your local chapter of March of Dimes, your state Academy of Pediatrics chapter, or support groups for the conditions that we screen for. You can find a PKU support group or a galactosemia support group. They're going to be they'll probably be more organized, and they'll probably have a link to the health department already, or at least the specialist. And so that's a good way to get involved and move initiatives forward as well. And that's it for me. Are there any other questions?
This is Mark. Just one quick question.
Amy, I do have.
Mm-hmm.
Go ahead.
Okay. And it has to do with the discussion earlier about the lawsuits. So
Yep.
how do you track prevalence of different conditions in your state?
So we have a really great working relationship with our specialists, so we know all of the kids who are diagnosed with one of our disorders. They report back to us. That's inclusive of the ones we pick up and the ones that may be false negatives. So generally that's how we're able to know how many kids we pick up each year.
And do you publish that, or is it available on an annual basis?
Oh, absolutely. It's presented at every advisory committee meeting. And we are very aware of trends as well. So we notice when, for instance, and I think a few states have noticed this, that congenital hypothyroidism, the incidence is going up. So we do a lot of comparisons to try to figure out if we're seeing increases or decreases.
I have, this is Bill Donovan, I have another curious question for you on the lawsuit front. Down here in Texas, the main complainants in the lawsuit are people who actually don't have children that are directly affected by newborn screening. In other words, they don't have any incidence of a disease process. Have you found that the parents that are suing claiming damage are parents that do not have children that are affected, or are they parents of children that are missed?
The plaintiffs are all parents, whose children were not affected or are not affected, and they did not have a positive newborn screen.
So they're saying that because of the fact that their children were tested and screened, that their civil rights were infringed upon?
I think their damages, or what they're claiming, is just the emotional damage of knowing that the state has a sample of their newborn's blood.
All right, thank you.
Yeah.
Amy, my name is Chantel Murray. I have a quick question for you. When you were talking in regards to abnormal screens, do you all ever get any conclusive results? I know my son was born in Pennsylvania, and ours came back inconclusive for cystic fibrosis. And if you do get those, what do you direct them to do? Do they have to get a repeat screening?
Yeah, so we call them borderline results in Minnesota, which I am assuming are the same thing. So it's not an obvious positive, but it's not really in the normal range as well. So our genetic counselors still call those out, and then we just request a repeat. Yep.
Okay, thank you.
Yeah.
I actually have a question. This is Julie Miller in Ohio. There seems to be a disconnect between children who pass away from rare disease and follow-up from the primary care provider through to the state, the federal level, the CDC, the NIH, and I would assume that contact and that follow-up, it would bring these diseases to the forefront to have them on newborn screening. How do you think that would be best addressed?
Okay, there was some feedback, so I just needed to repeat that really quick. I'm really sorry.
Let me see if I can do it.
Just the last part.
Okay. My concern is there is no follow-up between providers, the doctors who see these things and say an infant passes away from a rare disease that is not on a newborn screening panel. There's no follow-up between these providers and the state, the federal levels, the CDC, the NIH, and obviously many of these rare diseases are not on the state panels. So with this gap in communication, how is it that we could address, or do you address, these things being brought to the forefront and possibly being placed on newborn screening panels?
That's a good question. It may be different in Minnesota. Our metabolic specialists happen to see a lot of the genetics kids as well, so they see a lot of these rare diseases that you're referring to that aren't on the panel. Like I said, I go to the weekly care conference, which is both genetics and metabolism, so I hear a lot from them about their other conditions. I think that's really beneficial. So I hear a lot about the lysosomal storage disorders that are being considered to be on the panel. I think, I would say that as a state, we certainly don't reach out and solicit feedback about rare disorders, but we're very open to it coming our way. We've had parents come and talk to us about screening for Krabbe disease. About 2 years ago, we had a parent come and talk to us about pulse oximetry screening for congenital heart disease, and she, I think, single-handedly moved that forward in the state and nationally. So I think maybe we need to do a better job as a state to encourage those interactions. But if there's a parent who's out there, like I said, I would say contact your program. I think most programs are very open to listening to concerns or to questions about adding disorders to the panel.
Thank you.
Mm-hmm.
Right. Any other questions out there for Amy before we let her go?
Mm-hmm.
Well, Amy, I just want to thank you so much for taking the time to talk with us today. That was really great.
Perfect. I'm excited to see what you guys come up with.
Oh, thanks so much.
Yeah.
Okay, well, I think that's all the time we'll take for you today. And if any other questions come up, I'll be sure to pass them along, and then we'll just finish up with the rest of our meeting.
Perfect. Thank you guys so much.
Thanks so much, Amy.
Thank you, Amy.
Tam, can you switch over to my screen, please? All right. Great. Can everyone see my screen now?
Yes.
Okay, perfect. So just as a reminder, a couple people were still having a little bit of trouble understanding each other, so try and enunciate and speak really clearly just so everyone can understand what's going on the calls. A couple of housekeeping things that I wanted to take care of at the end of our call now. We've had some discussion that it would be really great to have task members interact a little bit more, share ideas. We're getting all of this, really helpful, useful information on the calls, but then there isn't really a place to further discuss it and, really have some of those conversations. So one of the things we've been discussing is a Google group versus a Facebook group, and I just wanted to get your guys' feedback. Google Groups are easier to share documents on. You can actually upload different things. But it is, if you're not used to them, it is a little more cumbersome to learn, whereas if everyone is already on Facebook, we can make a private group that only, our task force members would be able to access and then see the information that way. And I was just wondering if anyone had any feedback, if there's one format that they prefer over another, any features that they would definitely want to make sure are available, anything like that.
Hi, this is Stacy. Sorry.
Go ahead.
Okay. I would love to, I think this is a great idea. I do feel like there's a little disconnect after we have our monthly webinars. So I prefer, I'm not familiar with the Google group, but, I'm willing to learn. But Facebook would be great where we could interact with each other.
Perfect. Thanks for your feedback. Other options?
This is Christy. I would vote for Facebook. I'm on groups of both types, and Facebook just seems easier to converse.
Okay, great. Anyone else want to throw in their thoughts?
I was just going to say that I agree the Facebook is probably the best bet for interaction between members, but like I just explained at the beginning of the meeting, I asked you again about the Portability Act for the insurance coverage. Having a place that we have documents that are mentioned or are referred to in the webinars, that would be great to have a central location where all members know that they can go and find that information.
We had something available for a different body here with Baby's First Test where there was kind of a password login. Maybe I'll take a look and see if we can create something similar. No promises because I am not a web developer, but I will definitely check into it and see if maybe there's some kind of portal or login we can use on the Baby's First Test website to store, past meeting YouTubes, because I do only send those out to our task force members. I like to keep that a little more private, and then other documents like we're talking about. So I think that's a really good point. From the feedback I'm hearing, we'll start. Yeah?
Elizabeth, this is Christy. One other idea is on the Google group, there is a docs, create a docs section. It's not like a Word, you can't attach a Word document, but you can create a document and attach it to the group. So you could post links to the YouTubes and things like that within the group.
Okay, so maybe kind of a hybrid approach. We'll have a place where we can have all the documents, but we'll use Facebook as our main discussion piece.
And Elizabeth, this is Natasha. There is a piece of the website where we can have private sections just to store, like you said, the webinars and things. So that's pretty easy. We would just need to activate that.
Okay, yeah, I was thinking of the NAC area, and if we could we could take that over. Okay, great. Well, then we will work on that and get back to you. I'll send you invites if you can send me some of your information, or I'll add that onto the end of call survey. I have gotten some questions about the disbursement schedule. For all of you that I've received Exhibit A for, you will receive the first disbursement at the end of the training. We have one more training call, April 12th. And then the next disbursement at the submission of the project proposal. So what you're looking to do and interact with the newborn screening, just kind of writing that up a little more formally. And then finally the last disbursement with a final project summary report, which is, it's not anything intimidating. It's more what you did, what you learned, how this could be expanded to other communities, you know, what you wish you'd known more of, kind of a recap. So I've had a few questions, so I just wanted to make sure everyone had that schedule, and I will attach this PowerPoint to the end of call. For the end of call surveys, I've only been getting about 8 out of 10 people responding. This is a really great way for you to provide feedback so that we're making sure we're meeting the needs of the group, but it's also really important for our funders to show that we are having active participation and that we are meeting those needs. So it's something that we really need you guys to all complete at the end of the call so that we can continue discussing why we think it's so important to have a consumer task force and to really try and promote the consumer voice in the newborn screening arena. So please make sure that you're filling out those end of call surveys. Next month, we're going to be going through and we're going to be discussing social media with Mark. And so the end of call survey this month is going to have a few more detailed questions about your current level of use and knowledge so that we can tailor the session. So for example, if everyone is really familiar with Facebook, we're not going to go over the basics. We're going to talk about, you know, kind of more advanced things that you can do with groups and that sort of thing. If you can include your Facebook name so that I can link everyone up in the group I'm going to create this afternoon, that would be great so that we can get that rolling and make sure that we're all on the same page. We're also going to be asking you to create your own blog entry for the Baby's First Test website, highlighting your individual experiences or a hot topic issue you want people to know about. So if you want to talk about the blood spots, or if you wanted to talk about the Affordable Care Act, or if you wanted to talk about any of those things, we can definitely discuss that. What we had generally planned on talking about in our social media with Mark session is Facebook, Twitter, blogging, search engine optimization, Pinterest, and Instagram, some of the more popular ones. Again, I'll give you guys a scale where you can rate your familiarity with these different social media tools, and we can discuss how they can be used, how we're using them at Baby's First Test, and that sort of stuff. For the blog entry, we're going to ask that it's around 500 words. Again, this isn't school, we're not counting, but that's just to give you a ballpark of about how long you know, a good blog entry is for the website. Again, you can highlight either personal experiences or what kind of drew you to, or what an area you want to draw attention to the newborn screening community in, and it's perfectly fine to cross-post on your own personal or organizational blog. We can coordinate that easily, adding links to your personal websites or group organization websites, and just make sure that we're getting as much exposure as possible. This last part is going to be about the May Secretary's Advisory Committee meeting. Basically, the reason that we are excited to have you attend is because we want to make sure that, you know, you have an opportunity to interact and meet with the people who are on these panels that are making these decisions. We want you to see kind of the process of how diseases are added to the RUSP. So for example, at the January meeting, the DeGeorge group, their 22Q, made a presentation, you know, with their research about why they felt DeGeorge should be added as a newborn screening condition. So it's an interesting process to see and witness and kind of see what questions come up and how that all flows. There's an opportunity to provide a public comment to the Secretary's Advisory Committee, which we really strongly encourage. This is a place to make sure that the voice of consumers, of the public, is in these meetings. You know, the reason we really wanted this task force is because it's so easy to lose that consumer voice in all of this medical talk and discussion and budgets and states. And we just feel that it's so important to make sure that we're continually bringing up, the consumer voice. That's another reason we'd really love for you guys to attend. There's an opportunity to also attend the subcommittee meetings, such as the Education and Training Subcommittee. There is discussion of a national newborn screening awareness campaign that's likely to at least be mentioned. We don't have the agenda, but that has been a topic of discussion recently, so we think it'd be great for you to kind of hear about that and what's going on. In addition to the meetings, we're planning, a dinner where we can get to know each other and kind of discuss, get some feedback about proposed community projects, connect with fellow task force members, all of those things. It's great to have these calls, but it's really a different experience to meet face-to-face and make those connections. So we'd really like to provide an opportunity to do that. These are the people that I have confirmed to attend. I'm still waiting to hear from Mark and Key, so if you two can let me know relatively soon. We are going to start arranging travel and making sure all of that is taken care of. We will arrange for hotel rooms on Wednesday and Thursday night through our own account, so that's not anything that you guys would need to worry about. Most meals will be provided by the task force, so lunch both days. We'll have out together, dinner on Thursday night is when I was talking about we can really get together and talk. In addition, for like the breakfasts and the dinner Wednesday night, there will be up to $100 available for miscellaneous costs. We don't anticipate everyone will need this full amount, but we will try and make that available. And that's for anything additional. So if you need to take the metro from the plane or the airport or the train station, that kind of thing. What we're going to do is that you will book your own travel and we will reimburse this cost, but that must be pre-approved for us first. So basically just send a link like, this is the flight I'm thinking of taking from X to Y. This is the price. I've looked a few places. This is not specifically written into our budget, so we're just trying to be really conscious. So we know no one's going to go crazy, but just if there is, if there's a difference of $500 of leaving in the morning or the afternoon, we ask that you do keep that in mind so that we can keep having these types of events. And that's all of the housekeeping. I know the call went a little.
When do you want us to start working on that?
As soon as you'd like. Yeah, as soon as you'd like. I mean, our experience is that the sooner you book, the better deals you get. So, we're always going to be in favor of that. But, yeah, you can just send me a link, and then we'll just review it, make sure it makes sense within the budget, and then send the okay, and then we can reimburse those costs.
Okay.
Okay.
Elizabeth, this is Chris.
Yeah.
I'm at home now, but I'm having trouble pulling up the go-to. So would it possible? I can't see the slides. Would it be possible with email to send those out with the details that you
of course. Yeah, I'm going to send out both Amy's slides and the ones that I just went through with the end of call recap.
Perfect. Thank you.
So I have a couple of comments if I could, and then we can talk about this offline maybe. But I guess at some point I need to just get a sense of where, with our individual products, sort of what the timeline is and when we start focusing on that. On the social media stuff, I mean, I'm always interested to learn about it, but, for my particular focus, I'm not likely to need to use Pinterest or Instagram or some of those services, and I'm just curious as to why, do we really need to take the time on these important calls to focus on those topics? And it's for the group to decide, not just me, but just for me personally, it's not a particular focus of my project. So.
No, I think that's a really good point, and that's something that we can definitely discuss. The thought behind it was that is kind of how we're reaching the new generation of moms. They're using Pinterest like nobody's business, and we're really thinking about our target audience and who we're reaching out to. Internationally, we're starting to look and see that these are becoming world communities and not just silos. So that's the thought behind it, but I will definitely add a question to our end of call survey to try and gauge everyone's interest level and make sure that we are addressing these most important issues that you think are really going to benefit your project, and maybe an open-ended question on what you'd really like to see and what you think would be helpful.
Hi, this is Natasha. I'll jump in too. Elizabeth, that's a really good way of framing it. For us, it's also another important reason, or another reason why we thought of including it is because so much is going towards social media, and not everyone is familiar with it. But also, from a basic standpoint, it also helped us round out the idea of the Consumer Task Force being somewhat of a training. And this is definitely our first time going around and really having it be this more formal training. And so we kind of wanted to test out how does social media play out, what are other things that people, for future Consumer Task Force would they want to be trained on. And social media was something that HRSA, our funders, were very interested in, and interested in us speaking to other people about. So I think definitely with the way that the group answers the question in the survey this week will really help shape that. Any feedback is really helpful, in terms of maybe the amount of time that's focused on that is limited. So instead of most of the call, maybe we focus on just half of the call, just 30 minutes. Any type of feedback like that, we'll definitely try to accommodate. And it's definitely one of those things, everyone's kind of all over the spectrum on that, but any feedback around that, or if there's something else that you would want training on, it's not social media, but it's something else. We're definitely open to that and making the project better as it goes along.
As for the actual projects, after the April call, that's when we're going to start formulating those ideas and moving forward a little bit more. We were planning on using, because so many people have shown an interest in coming out to DC, using that May meeting as the call. Discussing those projects, so everyone coming with an idea and kind of working and talking it out there. So that's when the bulk of it will really start coming together. All right, well, that's all I had for today. I think a lot of really great ideas and discussions started at the very smallest level on the call today, so I look forward to getting some of those up on the Facebook group so everyone can really kind of talk and discuss around those. Again, please, we'd love to hear your feedback. We really want this to be a useful and interesting opportunity for all of you, so please let us know how it's going, thoughts, what you want to see more of, less of, and we're happy to take that into consideration. All right, well, I think that's all I have. Any questions or comments that everybody wants to share with the group?
This is Christy. I have a question on the blog post.
Yeah.
I just did one last night. Do you want something different than that, or do you want us to? I just realized it's kind of long, but can you post something on your own blog and then you guys link to it, or do you want something specific that's just for baby's first test?
I haven't had a chance to take a look at it yet. Can I get back to you offline on that one? Okay, perfect. Anyone else?
I just have a comment for the group. Being in Texas and having experience with the fact that there has been a tendency to take a legal attack stance on newborn screening by people who don't really understand the program. I want to encourage each and every one of us to be vocal about the importance of newborn screening. It just speaks volumes to me that all the people that go through the route of lawsuits are people that don't have children that are affected by behavior disorders. It just seems kind of, I don't, it seems to me kind of ironic that people are attacking the program which can protect children when they don't understand it or aren't affected by it. I think it's very important that those of us who have knowledge or are affected by it in some way, i.e. myself with two children that have been directly affected by newborn screening, or Christy, who has a daughter that, you know, is trying to find an answer, speak up and add a counterweight to those voices, because they seem to get a lot of attention in the media.
Thanks, Bill. I think that's a really great point, and I hope that, you know, on the Facebook group we can, you know, share articles and discussions and tips and pointers that we found useful in the various arenas. I think that'd be a really great use of that space. All right, any last comments or discussion points before we get going?
I have one. This is Christy, and this might be something that I want to pick everybody's brain and ask if maybe they can put comments on the Facebook page. Something that she said struck me in her presentation about practitioners kind of having that in their mind, that if the newborn screen is negative, that they might not ever come up with the idea that there might be a metabolic disorder presenting in front of them. And I just wondered if anyone has any experience as to the length of time that can go by before some of these disorders can show up, even if it's past the newborn period. And the reason I ask that is because that's kind of our situation. Is I have the documentations from our newborn screens, and everything was fine for my daughter and my son. We did not do the expanded newborn screen, but I just wonder if that's another key education piece in this whole puzzle, is knowing that it is just a screen, but the idea maybe being out there that it is